Hello and welcome to Talking Treatment, the podcast for everything in the field of mental health and addiction treatment. I'm your host, Derek Dorado. Ending the stigma on behavioral health and substance use disorders is very important to us, and the easiest way to do that is by talking about it. That's Talking Treatment. Today we have two special guests, Coletta Dorado, the founder and CEO of AZZLY, and Michael Harris, Director of Substance Abuse Residential Telehealth Services at Park Place Behavioral Healthcare in Kissimmee, Florida. Thank you for joining us.
Thank you for having me.
No. Even the direction where we went when talking about even the fentanyl, let's just pick up where we left off even there.
Okay. Well, what I've been witnessing and what the users are telling me is that initially the thought was they're lacing it with fentanyl to increase sales per se by showing X amount of deaths, whatever, and we got the strong stuff.
Right,
here.
yeah.
The most interesting thing, though, is that wasn't the case. This real situation is that they're actually getting people more tolerant to heroin,
Right.
where they can't get high off opioids and they need the next level stuff. So what we're seeing now is these dealers have actually slowly, very slowly, increased the tolerance of users to get them off heroin but onto fentanyl. And these are analogs. These are fentanyl analogs, right? So they're making their own. And that is the most interesting thing, is because we see people coming in all the time are tested negative for opioids but showing the withdrawal symptoms of heroin and opioids. And unless you're testing for fentanyl, if you give them a certain medication, they can suffer greatly. But the wonderful thing is we're still seeing some MAT work on the fentanyl. So for instance, we're seeing the Vivitrol have the same positive effect on fentanyl users as we do with opioid.
Okay.
So it's actually reducing their cravings and causing them giving them the same opportunity as it would for anybody using heroin, which is absolutely amazing. The issue is, though, we're seeing people use methadone and Suboxone. They're still having cravings if they're using fentanyl. And that's a very dangerous situation, considering that they're both agonists and you can easily overdose if you go back out there with the Suboxone in your system and you use something that's fentanyl and you're done. But that's what we're seeing a lot of right now. It's fentanyl everywhere.
So let's talk about Park Place Behavioral Health and the evolution that they've gone through, because it's 40 years, is that correct?
Yes.
Been around. So when they first opened their doors, was medication-assisted treatment
No.
even part of the program? Let's talk about that.
Medication-assisted treatment, I actually originally brought into the facility. It was not part of the equation. Actually, it wasn't part of many facilities' equations 5 years ago. It was. This is fairly new for people to really hop on board with this, and there was a tremendous resistance for it. Not just, like I'm talking about my facility. I'm talking about within the county, within the state. I mean, there's a tremendous resistance for it. I remember FATA, when I first joined Park Place, they had an incredible amount of money in funding for all types of MAT, and people weren't even taking it. And now they don't even have enough funding. So what has changed in 5 years is just incredible, and it's because people are seeing how well it works. But when we first brought it on board, we started with the Vivitrol, and instantaneously seeing some really amazing things. Somebody shooting 20 bags of heroin a day, we could detox them in 4 days using Subutex. Okay? And then we transitioned them onto Vivitrol within 7 days. And the very first night of receiving that injection, they will say how all their dreams have disappeared. They don't have any more dreams. And within less than 7 days of that first injection, they saying that they have no cravings. They can't even think. When they try to think about partying, as they call it, they describe it as their thoughts kind of dissolving, like they can't follow a thought all the way through to even complete that desire.
Excellent.
And as we started to see this, it was really quite amazing. So our program jumped from 1 or 2 people to now we're serving close to 70, 80 injections a month. And these people, each one of our individuals have met a minimum of 3+ injections. So we're averaging close to 6 to 8 injections per person, which our success rate is fairly high because of that.
So with the introduction of medication-assisted treatment into your program, you had the heavy lifting of convincing staff
Oh, yeah.
and getting their buy-in that, abstinence works for some, it doesn't work for everyone. And so getting that buy-in was your first struggle. Getting the buy-in, how about from board, how about from your leadership? Was that a tough struggle?
The number one barrier, and I've been called in to help other hospitals and facilities, and it's the same barrier each time. It's the doctors, it's the medical directors.
I
Wow.
wondered.
Okay? I've noticed 2 things. They either A, are not really educated on how this medication operates, so they design their protocols out of fear. And it's the most amazing thing, okay? Because they're more concerned with people getting put on these medications and going out and overdosing and dying,
Right.
All right.
Yeah.
right? Which they're more concerned with that idea than someone leaving their facility and getting high and overdosing and dying. Okay, when you give someone one of these medications, the chances of them using again drops tremendously. If you don't give someone a medication, their chances of using again is around almost 100%. So they were more concerned with their license or other things, and that was number one. Number 2, they came from a much older school of thought. Okay, I've noticed a lot of doctors, especially the medical directors, they're much older. They come from an older school of thought. They have yet to transition to the technology we have today, the medications we have today, these new styles. And there's no standard of care right now for this. That's the other thing. I believe we set up a standard of care, and I have yet to see a better one than what we have.
Excellent.
I even had some hospitals reaching out to me for our protocols and how we operate, because we can detox someone, like I said, in 4 days. They want you to wait 7 to 10 days to get them on certain medication-assisted treatments. We can do it in less than 7 days. Because we have doctors.
Fear? Is it fear?
It's because when you put an antagonist in the system, such as naltrexone or Vivitrol, and if you still have any form of opiate in your system, picture
Cold
it like
turkey, right?
right. Picture it like that. The medication is going to be stronger than the opioid to those receptors, so it's going to come on board and knock those.
You're not high anymore.
And immediately precipitate withdrawal. So the goal is you want to make sure all that is off the receptors before you put them on the injection. But if you have certain doctors and medical staff that are truly wanting to get trained and understand how these medications work, then you have a team like ours where they can detox someone in 4 days and get them on an MAT in 7 days. They don't live with that anxiety or that fear. They know what they're doing. They know how it's all operating. So if someone goes into a bit of withdrawal, they have a little bit of sniffles, nothing to worry about there.
It's not painful.
Not painful. Put them on the medication. The biggest concern is them leaving without the medication, right? So we can do it within 7 days.
That's huge. That's absolutely huge.
And why that's so huge is because if you miss that, you give anybody an opportunity, gap to leave, they're going to use it again.
Absolutely.
How's the success rate? How are you seeing, especially in the community of Kissimmee, and then it being outpatient and detoxing outpatient? That's hard.
Well, what I have done is actually we have an inpatient
Okay.
detox. So what we do is we bring it into our inpatient detox.
Okay.
And to prevent that gap, we have a residential component. So they never leave until they get on that medication.
Excellent.
And for people who even have jobs, like I said, we can do this in 7 days or less. So we can safely detox them, monitor them, have nurse, medical care, and on a MAT within 7 days so they can get back to their life, feeling totally fine, but also with the help of medication-assisted treatment.
Yeah, excellent.
That's
And see,
amazing.
that's key, is that physicians and medical staff are used to medication treatment. what is introduced in behavioral health and addiction treatment is medication-assisted treatment. So
Exactly.
can you talk a little bit about the difference there, and what is that assisted component? Is it what you just described, in that we're assisting you with your treatment plan, in that by being placed in a residential, you're monitored, your care is managed, you're stabilized before you're set out?
It's actually all that plus more, in my opinion. You give somebody medication for depression, okay? That medication doesn't cure them of depression. There's no cure for depression by using medication. The ironic thing is, they should call that no different as medication-assisted treatment. This medication can alleviate your depression. It can operate in a manner to help alleviate the symptoms. But if you notice, people that go into therapy for depression while they're on medication, that medication takes that weight of depression off. Maybe even helps allow them to understand what they could never understand in therapy before, because now they can think more clearly, they are more receptive, because that weight isn't there. Imagine what they could practice, the tools that they can learn, the skills that they can learn, right? That they can actually alter their cognitive pathways, change the way they think, okay? Medication-assisted treatment is necessary for opioids because if there isn't something there assisting the individual on a biological level from those cravings and taking that off, how are they ever going to learn the skills to recover?
You're just going to keep repeating.
Exactly. This is a chemical thing. In my personal belief, there's no way to beat. I mean, yes, I'm sure there are very few people who've done it, but for the general population, there's no way to beat the opioid epidemic without medication. These receptors have been taught to be activated by a chemical, and they respond to that chemical in ways that your body was never taught to do. And the second that chemical is out of the system, it's not just that these receptors want more of it. Other hormones are being produced now because these receptors are no longer activated. Cortisol, the stress hormone, is going to be beyond increased at that point. And they're doing studies on this now, which is incredible, that your own opioid receptors in your body, when you are developing, they themselves, when they're activated at a healthy level, keep the cortisol or stress hormone in check. And when they're not activated, you're seeing more cortisol in the system.
More stress and all that. Yeah.
Right? So if you experience an early life traumatic event, it increases the stress hormone. But that also decreases the ability for your own natural opioid receptors to work. So they're starting to see a strong correlation between early life adversity or traumatic events and the use of opioids later on in life.
To kind of
compensate for it.
to compensate it.
Interesting, very interesting.
This is a biological thing.
So you're very knowledgeable on the clinical, medical, and I'm sure you had to get that way in order to educate the physicians and those clinicians that you work with, so congratulations on that. So you said you had to get the buy-in of leadership as you introduced Matt into it, you had buy-in of the medical, buy-in of the clinical. What about the community? How embracing is the community? How did you have to overcome any objections in introducing Matt into your area?
And not just community, just to add on to that, not just the community of the people, but I'd be curious as well as your fellow clinicians around you, because not every clinician is so
gung-ho about it.
open-minded about Matt.
The community, the clinicians, there are so many different barriers to it. It was incredible. One of the worst barriers was hospitals putting people back on opioids.
Right.
You know, they know
Stronger
what
ones, too.
Exactly. They know what to say. When they know how to admit themselves to a hospital and know what to say to get morphine. They know what to say to get certain medications. And you can send a chart with a patient saying that they're on MAT, and we're still getting patients back being treated with opioids in hospitals.
Boy.
So talking about buy-in from the community, you have to educate everybody around you, because if you're on the path to try to help somebody with this, somebody at a hospital can easily just swipe that away instantaneously. They think that they're helping them, but they're not. And so we had to get the buy-in from county commissioners, judges, hospitals, which was a wonderful opportunity to do something that I believe a lot of communities lack, which is to build open communication and partnerships with the surrounding facilities of any kind, okay? And that's hard to do because everyone's their own little island, everyone wants to protect their own population or money or whatever it is. And working together, is, unless it shares a very specific component, it was never, let's just open up and work together to help everything. So this was an opportunity. This honestly, I felt was an opportunity. So I personally went to judges, I personally went to these ED directors, I personally went to the county commissioners, I personally got involved in speaking for FATA and things like that, because without everybody on the same page with these barriers, you could treat somebody, you can help them, you can help their family, and instantaneously, they can be wiped away again.
Yeah, excellent. No, it makes a lot of sense, and absolutely understand that process.
The numbers are staggering too.
They are. So it's interesting, even amongst the conferences that we attend in order to expand our knowledge, sitting in sessions and on panelists, whenever MAT, medication-assisted treatment, was discussed, I want to say 3 years ago, it was shocking that they felt the devil just entered the room, and how non-responsive anyone was in the room. I have noticed with my team when we went to the AATOD conference, in order to educate ourselves on addiction, on methadone, on Suboxone, on Vivitrol, and the acceptance of MAT, for the first time this past year, I saw a change. Are you noticing the change as well? Are more embracing the fact that medicine has to be applied to behavioral health, mental health, addiction treatment?
I'm definitely witnessing the same thing you are. I think one of the biggest influencers of that is a change in leadership at some places. And I have met some of these change in leadership individuals that have come in, have been brought in at least to make these changes, which is a great sign that those above, whether they be the board members or the judges, are on board. But you're right, when this first came out 3 years ago, Suboxone, methadone, the stigma surrounded with, they were the devil. It was, we're supposed to have a school of thought where abstinence is the only way.
Medicine caused a problem. There can't be the solution to the problem. If we didn't introduce the medicine in the first place, there wouldn't be an issue.
And what I find is those that live through the methadone, all the methadone clinics opening up, 50 years, it's been around for 50 years, have a certain fear that all of a sudden drugs are going to displace
12-step.
12-step, exactly. Yet then when you go to these conferences and you meet individuals that are working, have a family, have children, have a life, and they are on a maintenance medication, whether it be methadone, Suboxone
or
Vivitrol, you realize there's hope. There is a benefit for some individuals, so why shouldn't it be an option? And then when SAMHSA, Joint Commission, all these associations are stating, Carf, it's best practice.
Yes.
So how can a clinic refute that and not have it as an option? Is that discussed at many of the conferences or on the meetings?
Beyond belief. It still is amazing today to see how many clinics. We get referrals from people who come to us because they would say X, Y, and Z does not have this as an option. Okay? There are counties right now, entire counties, that do not even have it as an option.
And is it at the county level that they won't allow it to be introduced, or is it all the way down to the facility level or agency level that are choosing not to do it?
I believe it's the agency level at that point. It's those that are overseeing the agencies are not saying, hold on, let's see what's going on here within our substance abuse programs. Because I've seen counties bring in providers that have a school of thought that's still very old, the abstinence school of thought. Okay, that's absurd. Tell somebody who has diabetes, no medication. Okay, that's a maintenance drug. That's a maintenance medication. If we have somebody who has issues with, let's say, the opioid receptors, and you have a medication that can balance those opioid receptors and give a person relatively what would have the quality of a normal, healthy life, why not use it? Especially when it's available in 3 different formats. Why not use it? And that's what's the most frustrating thing, is that there's a stigma associated with it. Well, you did this to yourself. You use these drugs. You did this to yourself. Okay. Well, just yesterday in a group, somebody said, well, you didn't have to eat all that sugar. You didn't have to eat all those foods. You know,
Right.
Why is it
The shaming and the guilting of it all plays in.
Why is there a stigma associated with my condition but not with others, right? Why is the government making it so easy to get test strips and to get these medications for diabetes, but the second they do it for my condition, you know, I'm being shamed for it, right? And it's interesting to hear them talk in these groups, because it's, you know, they're very invested in their recovery. And they're doing everything they can to make it work for themselves. Methadone has a nasty rap because, and let's be honest, it's one of the oldest, right? It was a standalone medication. It's been around, you know, forever by itself until some of these others came out. But it has reduced HIV, it has reduced Hep C, and it was the only medication probably up until the last year that could ever be used with pregnant women.
Yes.
That's right.
Yeah.
Right? So how many women, mothers, and their children has it helped? Right? And that's the funny thing, is that people don't want to see that. They just want to see, oh, these fears that it's going to bring in more of this or more drugs or more drug use. They're doing trials right now on Suboxone, which is quite incredible. I know in South Florida, a couple of hospitals, one of my colleagues that I know down there, I could actually call him more of a mentor, he's actually heading up a program right now. It's showing that you can actually fully detox a pregnant woman and get her fully detoxed, so when she gives birth, there's no
Perfect kid.
Yeah.
Wow.
There's no addiction. That's huge.
I mean, this is all from technology. This is all from, you know, where we've come. If it weren't for methadone to help get us here in the first place, I mean,
To learn from.
to understand
Yeah,
that,
it's
you know,
the
this
building
is,
block.
There's always good players and bad players in every industry. I think that's a
Exactly.
fair statement. And there's abuses that do take place.
of course.
But what we're excited to see, our technology platform was originally designed to be a medical model. So we're very strong on the medical, which has played beautifully into what's happening in the introduction of MAT in behavioral health. Because in the past, and you've lived in this space, it seemed that there was just a lot of documentation, a lot of notes, a lot of narratives that didn't lean heavy on a medical director or a medical practitioner or medicine per se. It was more on the psychological, the biopsychosocial, and all the elements that affect it. So what we've been excited as we move into the medication-assisted treatment space, supporting those that use our software, is that they rely on a good MAR, a good medication administration record.
Yes.
In order to do that documentation. They rely on a good appointment report and to schedule of prior appointments, current appointments, future appointments, because it is that maintenance. It's knowing that the individual isn't taking the script you may be giving them and going out and selling it. Hey, they're coming back, and when they come back, what do? Possibly a urine test.
Right.
So it's that type of really engagement using a medical model that we see great success coming about, because it is medically based, and it's based on standards of care that have been proven in the medical industry to work. You give someone a drug, they take the drug, you prove that they are taking the medication because it's prescribed, right?
And that's probably where most people need to get better at, I'm gonna be honest with you, is the transfer of that type of information is so valuable. Okay, if you're running a MAT program of any kind, you need access to what medications people are taking, which means you need access to the prior medical records, right? This continuum of care model that is best practice is where people should be going. There are still barriers to that. And it's not always the programs or facilities that don't want to work. There's too many computer programs out there that don't have bridges, okay? So sharing chart information it's probably one of the next bigger obstacles to overcome with technology, because if you have let's say one medical record system and I have another, if there's no bridge API or something to allow us to share that information, then we're going back to old school methods here. Give the client a piece of paper to walk over to them with. Okay. I don't know if anybody, anyone of your listeners out there know this, but if you give somebody who has an addiction a piece of paper to walk over to a facility with, they're going to come over at some point, probably later on, but that piece of paper won't exist. Okay? Now, trying to get them to sign a release and then call the other facility up and make sure there's a release on file, the speaking and all this, it's a huge mess. And you cannot wait to go through all that to treat somebody. Okay?
Right.
So you start from scratch. You do your drug test, you do this, you do your own labs, and you start from scratch. Somebody has to start with that continuum care model. Somebody has to understand how the medical system works and how important medical records are and all this labs and all the medications that they're taking, and to share this information. There's funding out there for people that could already be in the system that have taken this injection or this medication, and if I had that information, I don't need to spend 48 hours or 72 hours trying to get them into the program. I could just immediately help them.
So where we've seen an improvement in that regard is most electronic prescribing systems out there. We use Dr. First.
Yes, we do too.
And so you can pull 2 years of history.
That is wonderful.
Which is fabulous.
Yeah.
I mean, a fabulous and easy tool. The other thing is the connection to the state PDMP.
Yes.
For the drug registry. Have they taken drugs or been prescribed a drug anywhere else? So you're right. Bridging the gap between a hospital and an outpatient ambulatory center, that communication in a standard language is still lacking, but at least there's tools out there for your benefit, right? The PDMP, direct access, as well as the e-prescribing, excellent. Your labs are your labs are your labs that come back. It would be great if the insurance payers would share maybe a little bit more with y'all, but that too will happen.
Don't even get me started.
So you're right. You have some roadblocks to really keep the continuum of care a solid road, and not so rocky for the patients.
And I mean, that's the other thing is with technology today, we're doing telehealth. You can help people in their homes today.
It's brilliant, isn't it? We're excited to support that as well. It's so easy.
I mean, there's really no reason why someone who talk about access to care, right? Now access to care the gap is destroyed, if you think about it. We're setting up satellite places where if you don't have, let's say you don't have access to a computer or internet, hopefully you're within X amount of miles, and you can, and if you don't want to wait a month to get an appointment or 3 weeks, hop online and get with somebody.
Yes.
Like literally instantly. And once you develop that rapport, you can, I mean, there are programs out there, but what we're doing is you don't even have to come in. If you have a house with a computer or a cell phone, you can meet with a provider and get what you need instantaneously. You don't need to suffer. You don't need to wait. You don't need to, and that's the other thing is so many people when they come in and they're like, oh, I have to wait a month to get an appointment. Well, what's going to happen in a month? We've seen people die in a month.
Certainly.
Sure.
So as a business model too, it affords you the ability to contract with a per diem staff, a staff that likes to do the telehealth, might be very brilliantly skilled licensed clinical social workers or marriage and family counselors that are out there that don't want to commute 2 or 3 hours to your facility, but are offering their services and will do it in a
If
telehealth.
anybody out there is listening, you don't want to commute, but you want to work, just give me a call.
There you go.
Because I'm telling you, that is the most ingenious thing ever. It is that people today, everything's about instant gratification, and if we can bring instant gratification to when people want to receive help, I mean, are you kidding me? With a press of a button.
So let's talk about patient engagement.
Yeah.
One of the things on patient engagement, as easy as most have what? Smartphone?
Right.
Right? Texting.
Right.
Reminding them of their appointments. How easy is that to engage them? Is that important?
It is beyond important and so simple. And there are programs out there that not only will text you to remind you of your appointment, that you can even have them text you to remind you to take your medication. That type of care is where we're going, but it's still very rare, right? And I think why it's rare is because you have to find the staff that's knowledgeable in how to set that up, okay, in a facility. It's not that we don't have access to the technology, it's facilities finding the staff that are familiar with how to bring this technology into the hospitals or into their healthcare providers and give it to the patients.
So interesting. It circles back in all your discussion to education.
Right.
Educating within the community, educating within a staff, educating leadership, and educating enough about technology. And we agree with you 100%. We feel that that initial setup, training, and implementation functionality that a vendor with a product can do is critical, because it gets their buy-in and it gets them to use what it's not inexpensive, it's an investment. And so you might as well get the bang for the buck.
I mean, you want to talk about finances too. Think about a medical provider who hates having no shows, right? I mean,
They all do.
every one of them. This technology alone can decrease that
By
beyond
about
belief.
50%
Right.
are the studies. By about 50%. That's huge.
You know, if I were opening up a facility today, the number one, my initial first investment in anything would be the technology.
There you go.
It's the backbone of everything today.
Very smart, very smart. What we're seeing and you've converted an existing 40-year-old plus facility, the facility that you're with, to medication-assisted treatment. We're seeing a whole channel develop whereby smart business people with smart doctors are forming MAT clinics. And what they're doing is the doctors aren't there Monday through Friday, but they are contracted to work, maybe it's Monday, Wednesday, Friday, Tuesday, Thursdays, one day a week or whatever. And what we see is brilliant, Michael, is that they're serving the Medicaid population.
Yes.
That prior, only the non-for-profits had that huge responsibility and burden because of the massive population of those in need, especially for this care in your community, that we're seeing these clinics open up and being run as a business, but relying on technology
Right.
as the backbone of that business. It should be no different for a non-for-profit.
The interesting thing is that what we did 2 years ago, actually it's been 3 years now, we're not just a bake rack facility, we're also a Marshmack facility. So for everyone, for the Marshmack, it is a bake rack, but for substance abuse, okay? And a lot of people don't know this exists, which drives me nuts.
I don't think people know about it.
Marshmacks, you can literally just go, if you fear you have a family member or friend that is abusing substances and needs help, you can literally get a Marshmack from the court, or you can call the police, just no different than you would with a bake rack. They carry now one form that is for both, okay? And you can Marshmack somebody. So instead of them going to the CSU for drugs and alcohol, they would come to a detox, okay? Our Marshmack, our detox is set up where I got the judge online. So we don't have judges come to our facility anymore. We don't have to wait for a judge or a court team to come to our facility to meet with the clients.
It's all telehealth.
Yeah,
Nice.
it's all telehealth.
Nice.
Wonderful.
So they're there, detoxing, getting them healthy, getting them better. By the third day, when they're feeling better, they sit in a conference room with their court liaison and a nurse and the judge on the screen just like that. And that means that they can literally receive whatever treatment they need. And the family members may even be on the screen too with the judge, talking to them and deciding, is this gonna be a court order treatment, or we're gonna give you a chance to do this on your own, and we'll keep this open and enforce court next time. But you have it all right there before they even leave. The law right now is the way they have it set up, which is so costly, which drives me nuts, and I see facilities doing this all the time, and it drives me nuts, is they'll detox them, every Marshman Act, they'll detox them and release them. So they play this catch and release game where then they gotta call police to go out and find them. You get a pickup order to find them, to then drive them to the court, to be there on time for their court. That ain't happening. That's not happening. There's no way they're gonna find most of these people, right? And in between that gap, how many of them are overdosing? I mean, talk about the cost of the city and the finances and all this, but how many are not getting the help they need? We removed it. Meet with the judge before you even leave here.
Is that unique to the county that you're in?
I believe so, because I've spoken to other counties who want the help, they want my help to help establish that. They have yet to do it. So the way I did it was I purposely went
To the judge.
to the judges.
Yeah, I think your best bet is to have judges talk to judges.
And that was where we have a drug court program, and that's where I started. And by talking to the judge of the drug court program, I got an opportunity to sit down with the other judges. I got 15 minutes only, but I got to sit down with every single county judge, and that's all I needed. That's all I needed. The very next day, I got a call to say, come on in with your tech guy, and let's get you set up. It was the most amazing thing.
But having the buy-in at the right level
Right.
is critical, is absolutely critical. Michael, it's been a delight, again, having you here and having you share your experience, what you're doing in the community. It's fabulous, the fact that you're using technology, you're using new methodologies that haven't been used in the past in order to reach more. And isn't that the purpose? Serve more
Exactly. It is.
in your community on that. Is there anything else you'd like to share?
Oh, I can go on for days about this, but I mean, I just want, I guess the most important thing for me is to make people aware that this is available, the technology is available, the medication is available, and most importantly, and this is not guaranteed, but we fight for it every day, is it's funded right now. State governments are funding it. Medicaid is covering it 100%. This is out there, it's available, take advantage of it, because the biggest fear is the governments and the insurance companies don't see people utilizing it for their purpose and seeing how well it works. They're going to step back on it, and that's not what I want. I want this to continuously to be available, and what we do is we provide it for people who have insurance, Medicaid, but we also, we're the largest, I think the second largest provider for people who have no health insurance of any kind.
Wow.
So, and that's all coming from the state, and through those programs, we're helping to provide the data to the state to show how effective this is.
Is that all grant funded?
It is.
Yeah.
It's all grant funded. There's SOAR funding, there's OSCO funding, there's DCF funding.
Because I think a lot of our listeners are clinical directors, executive directors that are in similar positions, and probably, like, the whole theme of the conversation really has been about education. Getting started, right? Where do I even get started? I speak to people every day, and they're either just getting their licensing or going through the process or maybe opening a new program, and a lot of times they're clueless on where to get started.
You only need, if you think about it, you only need about 3 things to have an MAT program, okay? You need funding, okay? Which there's available funding through the state government right now, and federal funding. But even if you can't obtain that, all Medicaid right now is covering it. So treat Medicaid patients, okay? Help them. Number 2, you need a provider that can do it. And right now in Florida, they require an X number. I think it's even federal.
That's right.
Okay?
Mhm.
We, at our last meeting up in Sanford, made a suggestion to the Senate to get rid of it in Florida. Rather CEUs or something instead of that, because so many people are not, so many providers that could go get it are not doing it. It's a 24 hours online course is if you time it at 24 hours straight. Right? I mean, you can do it in 2 days. I had a provider who did it in 16 hours. This provider is an APRN,
Oh, wow.
okay? And that's number 2. If you have an NP, they can get this X number. You don't need to be a psychiatrist, an MD or a DO. You can be a psychiatric nurse practitioner, and you can get this X number. Once you have the X number, you can then prescribe Suboxone. And it starts you off at serving 30 clients. And then it can jump you up to 250.
Yeah, it's the X waiver. It is controlled in that they do not say that you can serve and treat 1,000 people.
You have to ramp
Exactly
up.
what you
Right.
said, Michael. They have a very small starting rate, and it's very well managed and
It is.
monitored from what I understand. If you do prove successful, then they will increase it up to the 250 or 275. It is a good standard practice, and it affords those that have the skill set to open their doors. We are seeing many individuals that are very competent in the space, and maybe with facilities that aren't innovative, aren't moving forward, have their brakes on for whatever reason. We're excited to help those individuals open their doors and give them the technology that they can then serve within their community, because there just aren't enough to serve the 20
not enough.
million population. There's not enough.
These are
treatment
30
centers.
individual people, right? Or 200, whatever number you're at. So my nurse practitioner, or my doctor, or my detox unit, if we have a 20-bed detox, and assuming all 20 of them are using, they're on this Suboxone taper, that's 20 of their 30 people they're ever allowed to serve. So until one is discharged, they can't put another one back in. That means if they all want to step down to outpatient, one provider can be filled up instantly and cannot legally serve another soul. And a person can technically be on this MAT for their entire life. They don't
Right.
need to be on it for 8 months. It can be a supplement as needed for their entire life. And that's the problem, is that 30, look at the numbers, 30 is not a lot. 50 is not a lot. 100 is not a lot. If you don't have at least 2 providers that are at 100, your ability to serve the community is very, very limited. Very limited.
And you have to remember, it's Medicaid reimbursement. It's not a large amount of
It's
money.
not.
It's very limited. So for any business that wants to serve this population that's in great need, it needs the support. I think your suggestion that they manage that number maybe more effectively in order to help serve the community, I think that's a point very well taken, and I hope you have a greater voice out there in order to do that.
That's pretty much it. Yeah.
Excellent.